Welcome to the series where I review the 2025 AACE Consensus Statement on the algorithm for the evaluation and treatment of adults with obesity or adiposity-based chronic disease. This is Endo in a Bite, where I break down complex concepts into bite-sized pieces you can actually remember. Today, we will discuss a practical and unified framework for response to therapy, weight loss targets, and intervention selection in patients with adiposity-based chronic disease. The core principle is straightforward. Weight reduction is required for effective treatment or prevention of obesity-related disease. The task force defines 3 categories of weight reduction that correlate with clinical outcomes. A weight reduction of 5% or less represents an incomplete response. This amount of weight loss is often insufficient to meaningfully treat obesity-related complications. A weight reduction greater than 5% and less than 15% represents a good response. This level improves many complications but may not be optimal for all. A weight reduction of 15% or greater represents an excellent response. This degree of weight loss is sufficient to prevent or improve a broad array of obesity-related complications and diseases. It is essential to recognize that individual response varies. The amount of weight lost and the degree of improvement in complications are not identical across patients or interventions. The goal is always to achieve enough weight loss to improve the specific complications present in that individual. Early response to obesity medication should be assessed after approximately 3 months on the full treatment dose. If at least 5% weight loss has not been achieved by that point, long-term efficacy is unlikely to be sufficient. This should prompt a change in therapeutic strategy, which may include intensifying lifestyle therapy, switching medications, or combining obesity medications. Patients who achieve 5% or greater weight loss at this early assessment should continue their current therapy. Ongoing follow-up remains important because therapy may still need to be intensified if improvement in obesity-related complications is not adequate. The intensity of therapy should match disease severity. Patients with more advanced adiposity-based chronic disease or multiple complications require earlier and more aggressive treatment. Patients who achieve 15% or greater weight loss, which is the average response to second-generation obesity medications, reliably experience improvement or prevention of a wide range of obesity-related complications. When selecting obesity medications, relative weight loss efficacy must be considered. Head-to-head trials are limited, but Phase 3 data provide guidance. First-generation obesity medications approved for chronic use on or before 2014 produce average weight loss of less than 10%. Sustaining weight loss is critical. Weight regain leads to worsening of obesity-related complications. As weight loss occurs, medications for conditions such as type 2 diabetes, hypertension, and abnormal lipid levels may be reduced, but patients must be monitored closely and therapies adjusted as needed. Metabolic and bariatric surgery represents the most effective intervention for sustained weight loss and complication improvement. Procedures such as surgical sleeve gastrectomy and Roux-en-Y gastric bypass are well established with strong long-term safety and efficacy data. These interventions are particularly appropriate for individuals with severe obesity or obesity complicated by significant disease burden. Surgery should always be combined with nutrition therapy, physical activity, behavioral support, and when appropriate, obesity medications. Long-term success requires a multidisciplinary team approach. Lifestyle intervention is foundational for all patients. Now let me simplify how to think about complication-specific weight loss targets. Let's talk about the 5 to 10% group. This is where many obesity-related conditions first show clinically meaningful improvement. In this range, you see benefit for reflux, osteoarthritis, stress urinary incontinence, and hepatic steatosis. Now let's look at the 5 to 15% group. Here we see benefit for polycystic ovary syndrome, dyslipidemia, hypertension, and improved hyperglycemia. In the 7 to 10% group, we have type 2 diabetes prevention and obstructive sleep apnea. Now let's talk about the 10% threshold. 10% is a major inflection point in the table provided by AACE. This is the weight loss level associated with type 2 diabetes remission and meaningful reduction in atherosclerotic cardiovascular disease and major adverse cardiovascular events. 10% is also the minimum weight loss associated with improvement in MASH. Cancer prevention requires additional research to determine whether weight loss at this level provides benefit. This framework turns weight loss from a vague goal into a clinically targeted treatment strategy. By matching the degree of weight reduction to the disease burden, we can choose the right therapy for the right patient. This was another bite-sized episode of Endo in a Bite. In the next few episodes, we will be working through the details of the AACE consensus statement, the algorithm for the evaluation and treatment of adults with obesity or adiposity-based chronic disease, the 2025 update. Remember to visit www.easyendoprep.com to sign up for the weekly newsletter and have all the key pearls delivered straight to your inbox. You can also purchase the full board review course there for deeper learning and ABIM exam prep. Let's get through this document one bite at a time.